Ligament. Ionia N on EAI, dash dash a dash 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 a dash a. Dash a dash 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 a dash a dash a. Dash a dash 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 a dash a dash a dash a dash, Achilles tendon and posterior subtalar. I should not communicate. The Achilles J intel tendon does not have a E tendon sheath. I pisiform recess and radiocarpal joint, should normally communicate. I. Common pathology seen on MRI of the wrist eye hand. Triangular fibrocartilage tears, these can be acute or chronic. The acute one is going to be a young person with a tear on the ulnar side. The chronic one is more likely to be shown with ulnar abutment syndrome, positive ulnar variants with cystic change in the lunate. Degeneration of this cartilage is common, 50% at age 60. Scapholaunate ligament tear, the Terry-Thomas look gap between the scaphoid and lunate on plain film. There are actually three parts, volar, dorsal, and middle, with the dorsal band being the most important for carpal stability. Predisposed for DISI deformity and all that crap I talked about earlier. Kienbeck's, ain of the lunate, seen in people in their 20s to 40s. The most likely testable trivia is the association with negative ulnar variance. It's going to show signal dropout on TL 41. The Corvain's tenosynovitis, this is the so-called washerwoman sprain, or mommy thumb from repetitive activity I overuse. The classic history is new mom, holding a baby. The affected area is the first dorsal, extensor, compartment, extensor pollicis brevis and abductor pollicis longus. This is way more common in women. The presence or absence of an intratendinous septum is a prognostic factor. How it's shown. This can be shown with ultrasound as increased fluid within the first extensor tendon compartment. This can be shown with MRI as increased T2 signal in the tendon sheath. De Quervain's tenosynovitis. Intersection syndrome, a repetitive use issue classically seen in rowers, where the first extensor compartment cross over those of the second extensor compartment. The result is extensor carpi radialis brevis and longus tenosynovitis. 42. Tenosynovitis. This is an inflammation of the tendon, with increased fluid seen around the tendon. This will be shown on MRI. Diffuse. Focal. Non-tuberculous mycobacterial infection, the hand and the wrist are the most common areas affected. This is a diffuse exuberant tenosynovitis that spares the muscles. It usually occurs in patients who are immunocompromised. Rheumatoid arthritis. A nice trick is to show that multiple flexor tendons, or extensor carpi ulnaris, tenosynovitis can present as an early RA before bone findings. Overuse. This is going to be classic locations like first extensor compartment for decay of veins. Infection. The hard rule is that tenosynovitis of any flexor tendon is a surgical emergency as it can spread rapidly to the common flexors of the wrist. You can get increased pressures and necrosis of the tendon. Tendons. Delayed treatment tend to do terrible. Gamesmanship wrist compartments isolated 1 street DK veins, LST plus 2 ND intersecting isolated 6th early RA multiple flexors RA. Dubitrin contracture, this is the most common of the fibromatoses. The classic scenario is a white person from North Europe with alcoholic liver disease. It's a nodular mass on the palmar aspect of the aponeurosis that progresses to cord-like thickening, and eventual contracture, usually involving the fourth finger. It's bilateral about half the time. 43. Finger tumor, they can show scalloping on a plain film of the finger, but if they want a single diagnosis they need to show a MRI. There is a long differential, but the only things they are going to show are glomus tumor, this is a benign, painful vascular tumor, hamartoma, seen at the tips of fingers, 75% in hand. It will be TL low, T2 bright, and enhance avidly. Pain disappears with a tourniquet. Hildreth sign looks like a glomus, T2 bright, but has a histocy of trauma. Consider epidermold. Another clue might be the word painless in the description. Glomus tumors are painful. Painful. Giant cell tumor of the tendon sheath. This is basically PVNS of the tendon. Typically found in the hand, palmar/volar tendons, usually first T3. Can cause erosions on the underlying bone. Will be soft tissue density and be TL and T2. Dark contrasted to a glomus tumor which is TL dark, T2 bright, and will enhance uniformly. Will bloom on gradient. Fibroma, this is a benign overgrowth of the tendon collagen. Favors the flexor tendons of the fingers. It's going to be low on TL and low on T2. Will not bloom like a GCT will. Fingertip tumors/mass S __ equals 1. IITI dark, T2 bright, enhances IT2B. HTEHA DJIG OMAS IDNG, NNS V1Y. AV1IR dash dash a dash a dash a dash a dash a dash dash a dash a 1I dash a dash dash colon dash 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 a dash. Giant cell tum or tendon eye enhancement, usually, bloom on gradient, II on gradient, IJTI, dash a dash a dash a T a dash a dash a -1. 1 TL dark T2 dark. Variable I. L.F1 broma, IN TNBL. I does not bloom on gradient. L. Ansman. O 1 LL, underscore 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 dot L underscore underscore underscore. '44. Common pathology seen on MRI of the elbow. If you are shown an MRI of the elbow, don't panic, there are only a few things they can show you. Cubital tunnel syndrome. The result of repetitive valgus stress. Anatomy trivia, the site where the ulnar nerve passes beneath the cubital tunnel retinaculum, also known as the epicondyloolecranon ligament, or Osborne band, can occur from compression by any pathology, tumor, hematoma, etc. When it occurs from an accessory muscle, it's classically the anconus epitroqueres. Partial ulnar collateral ligament tear. For the exam, all you really need to know is that throwers, people who valgus overload, hurt their ulnar collateral ligament, which attaches on the medial coronoid, sublime tubercle. The ligament has 3 Lateral epicondylitis, more common than medial, seen in tennis players, extensor tendon injury, classically extensor carpi radialis brevis, radial collateral ligament complex, tears due to varus stress. Medial epicondylitis, less common than lateral, seen in Gaffer's common flexor tendon and ulnar nerve may enlarge from chronic injury. Epitrochlear lymphadenopathy, this is a classic look for cat scratch disease. Dialysis elbow, this is the result of olecranon bursitis from constant pressure on the area, related to positioning of the arm during treatment. 46. Common pathology seen on MRI of the shoulder. Lateral epicondylitis, more common than medial, seen in tennis players, extensor tendon injury, classically extensor carpi radialis brevis, radial collateral ligament complex, tears due to varus stress. Medial epicondylitis, less common than lateral, seen in Gaffer's common flexor tendon and ulnar nerve may enlarge from chronic injury. Epitrochlear lymphadenopathy, this is a classic look for cat scratch disease. Dialysis elbow, this is the result of olecranon bursitis from constant pressure on the area, related to positioning of the arm during treatment. 46. Common pathology seen on MRI of the shoulder. Impingement I rotator cuff tears, this is a high-yield eye-confusing subject that is worth talking about in a little more detail. In general, rotator cuff pathology is the result of overuse activity, sports, or impingement mechanisms. There are two types of impingement with two major subdivisions within those types. Like many things in radiology, if you get the vocabulary down, the pathology is easy to understand. External, this refers to impingement of the rotator cuff overlying the bursa. Surfaces, superficial surfaces, that are adjacent to the coracoacromial arch. As a reminder, the arch is made up of the coracoid process, acromion, and coracoacromial ligament. Primary external causes, abnormal coracoacromial arch. The hooked acromion, type high Biglian E, is more associated with external impingement than the curved or flat types. Subacromial osteophyte formation or thickening of the coracoacromial ligament. Subcoracoid impingement, impingement of the subscapularis between the coracoid process and lesser tuberosity. This can be secondary to congenital configuration, or a configuration developed post-traumatically after fracture of the coracoid or lesser tuberosity. Secondary external causes, normal coracoacromial arch. Multidirectional glenohumeral instability, resulting in microsubluxation of the humeral head in the glenoid, resulting in repeated microtrauma. The important thing to know is this is typically seen in patients with generalized joint laxity, often involving both shoulders. Internal, this refers to impingement of the rotator cuff on the undersurface, deep surface, along the glenoid labrum and humeral head. Posterior superior, this is a type of impingement that occurs when the posterior superior rotator cuff junction of the supra and infraspinatus tendons comes into contact with the posterior superior glenoid. Best seen in the aber position, where these tendons get pinched in the eye burn and greater tuberosity. This is seen in athletes who make overhead movements, throwers, tennis, swimming. Anterior superior, this is internal impingement that occurs when the arm is in horizontal adduction and internal rotation. In this position, the undersurface of the biceps and subscapularis tendon may impinge against the anterior superior glenoid rim. 47. External. Internal. / R. Primary * abnormal coracoacromial arch. Hook-shaped, 83, osteophytes, post-traumatic, thickened ligaments. Secondary * multidirectional instability, labrum often normal, increased glenohumeral volume with injection. Subacromial * Fs with supra S. Subcoracoid * Fs with sub S. Posterior superior _ If the exam writer's * throwers just say internal, Fs with infraspinatus, and posterior supra, impingement, posterior superior labrum torn, this is the one cystic change in greater tuberosity they are talking. Anterior superior, associated with subscapular damage, may be the cause rather than the result, anterior superior labrum torn. About L high yield trivia points on impingement. I subacromial impingement, most common. I form, resulting from attrition of the I. Damages supraspinatus tendon. 1. Adhesive capsulitis, frozen shoulder, an inflammatory condition characterized by a global decrease in motion. You can have primary types, but a multiple CHOE key would be a history of trauma or surgery. It most commonly affects the rotatory cuff interval, and that is the most likely spot they will show it. The classic look is a T1, or non-fat set T2, in the sagittal plane showing loss of fat in the rotator cuff interval, the spot with the biceps tendon, between the supra-S and the subscap. Gray smudgy shit instead of clean fat in the rotator cuff interval. Buzzword, decreased glenohumeral volumen, with injection. Remember, multidirectional instability was increased. Buzzword, thickened inferior and posterior capsulin. Buzzword, enhancement of the rotator cuff interval post-GAD. 49. Rotator cuff tears. People talk about these tears as either bursa-sided, meaning the top part, or articular. Gray smudgy shit instead of clean fat in the rotator cuff interval. Buzzword, decreased glenohumeral volumen, with injection. Remember, multidirectional instability was increased. Buzzword, thickened inferior and posterior capsulin. Buzzword, enhancement of the rotator cuff interval post-GAD. 49. Rotator cuff tears. People talk about these tears as either bursa-sided, meaning the top part, or articular-sided, meaning the undersurface. A tear of the articular surface is more common, 3x more, than the basal surface. The underlying mechanism is usually degenerative, although trauma can certainly play a role. The most common of the four muscles to tear is the supraspinatus, with most tears occurring at the critical zone, 1 to 2 centimeters from the tendon footprint. This relatively avascular, critical zone, is also the most common location for calcium hydroxyapatite, HADD, or calcific tendinitis. The teres minor is the least common to tear. A partial tear that is 50% often results in a surgical intervention. Massive rotator cuff tear refers to at least 2 out of the 4 rotator cuff muscles. A final general piece of trivia is that a tear of the fibrous rotator cuff interval, junction between anterior fibers of the supraspinatus and superior fibers of the subscapularis, is still considered a rotator cuff tear. How do you know it's AFULL thickness tear? You will have high T2 signal in the expected location of the tendon. On TL you will have GAD in the bursa. Full thickness tear, with GAD crossing over the cuff into the bursa. 50. Injury to the labrum. SLAP. Labral tears favor the superior margin and track anterior to posterior. As this tear involves the labrum at the insertion of the long head of the biceps, injury to this tendon is associated and part of the grading system, type 4. Things to know about SLAP tears. When the SLAP extends into the biceps anchor, type 4, the surgical management changes from a debridement to a debridement and biceps tenodesis. The mechanism is usually an overhead movement, classic equals swimmer. People over 40 usually have associated rotator cuff tears injury. Not associated with instability, usually. SLAP mimic the sublabral recess. This is essentially a normal variant, where you have incomplete attachment of the labrum at 12 o'clock. The 12 o'clock position on the labrum has the shittiest blood flow, that's why you see injury there, and all these development variants. Follows contour of glenoid smooth margin located at biceps anchor. Extends laterally ratty margin located at biceps anchor and 51. Labral tear mimic, the sublabral foramen, the is an unattached but present portion of the labrum located at the anterior superior labrum, 1 o'clock to 3 o'clock. As a rule it should not extend below the equator, 3 o'clock position. Labral tear mimic, the Buford complex, a commonly tested, and not infrequently seen, variant is the Buford complex. It's present in about 1% of the general population. This consists of an absent anterior/superior labrum, 1 o'clock to 3 o'clock, along with a thickened middle glenohumeral ligament. Buford complex, thick middle GH ligament. 52. L. Bankart lesions. There is an alphabet soup of Bankart, anterior dislocation, related injuries. J. Glad-Pertas Alpsa Bankart, cartilaginous, osseous. GLAD equals glenolabral articular disruption. It's the most mild version, and it's basically a superficial anterior-inferior labral tear, with associated articular cartilage damage, impaction injury with cartilage defect. Not typically seen in patients with underlying laxity. It's common in sports. No instability, Aaron 1 you glad there is no instability. Memory aid, Perth ES equals detachment of the anteroinferior labrum, 3 to 6 o'clock, with medially stripped. 6. The detached RR. 6. Labrum sorta and looks like a but intact periosteum. P. Alpsa equals anterior labral periosteal sleeve avulsion. Medially displaced labral ligamentous complex with absence of the labrum on the glenoid rim. Intact periosteum. It scars down to glenoid. True Bankart can be cartilaginous or osseous. The periosteum is disrupted. There is often an associated Hill-Sachs fracture. Glad Pearl he's Alps a true Bankart. Superficial partial avulsed anterior similar to Perta's, but Tom labrum. Labral injury with labrum, only with bunched-up cartilage defect minimally displaced. Medially displaced inferior GH complex still attached to periosteum. No instability intact periosteum DL erupt, lifted up. 53. Posterior glenohumeral instability. As I mentioned previously, anterior shoulder dislocations are way more common than posterior shoulder dislocations. Therefore the Bankart, Alpsa, Pertas, etc., are the ones you typically think of as the stigmata of prior dislocation. However, all that shit can happen in reverse with a posterior dislocation. Reverse osseous Bankart, a fracture of the posterior inferior rim of the glenoid. Pulpsa, this is the bizarro version of the Alpsa, where the posterior labrum and the posterior scapular periosteum, still intact, are stripped from the glenoid resulting in a recess that communicates with the joint space. Bennett lesion is an extraarticular curvilinear calcification, associated with posterior labral tears, maybe the pulpsa. It's related to injury of the posterior band of the inferior glenohumeral ligament. Kim's lesion, an incompletely avulsed flattened mashed posterior inferior labrum. A key, testable, point is the glenoid cartilage and posterior labrum relationship is preserved. 54. L. Miscellaneous, shoulder. HAGL, a non-Bankart lesion that is frequently tested is the HAGL, humeral avulsion glenohumeral ligament. This is an avulsion of the inferior glenohumeral ligament, and is most often the result of an anterior shoulder dislocation, thus like all the above Bankarts. The J sign occurs when the normal U-shaped inferior glenohumeral recess is retracted away from the humerus appearing as AJ. Axial MR, showing the IGHL torn at its humeral attachment. Subluxation of the biceps tendon, the subscapularis attaches to the lesser tuberosity. It sends a few fibers across the bicipital groove to the greater tuberosity, which is called the transverse ligament. A tear of the subscapularis opens these fibers up and allows the biceps to dislocate, usually medial. Subscapularis tear equals medial dislocation of the long head of the biceps tendon. Subscap tendon, forming portions of the transverse ligament that holds the biceps tendon in the groove. Subluxation of the biceps tendon occurs with a tear of the subscapularis. 55. Nerve entrapment, high-yield trivia. Suprascapular notch vs. spinoglenoid notch. A cyst at the level of the suprascapular notch will affect the supraspinatus and the infraspinatus. At the level of the spinoglenoid notch it will only affect the infraspinatus. I suprascapular notch _ Oated line equals suprascapular nerve. Nerve. Cyst in the spinoglenoid notch causing fatty atrophy of the infraspinatus. Quadrilateral space syndrome. Compression of the axillary nerve in the quadrilateral space, usually from fibrotic bands. They will likely show this with atrophy of the teres minor. Another classic question is to name the borders of the quadrilateral space, teres minor above, teres major below, humeral neck lateral, and triceps medial. Humerus. Quadrilateral space syndrome, atrophy of teres minor. Parsonage-Turner syndrome. This is an idiopathic involvement of the brachia plexus. Think about this when you see muscles affected by pathology in two or more nerve distributions, suprascapular and axillary etc. 56. L. MRI of the knee. I want to focus on how the exam is likely to ask the questions with two main pathways, 1. Total trivia, 2. And mini images. Anatomy. Ligaments. The ACL has two bundles. The long one, anteromedial, tightens the knee in flexion. The short one, posterior lateral, tightens the knee in extension. The PCL is the strongest ligament in the knee. You don't want a posterior dislocation of your knee resulting in dissection of your popliteal artery. Meniscus. The meniscus is C-shaped, thick along the periphery and thin centrally. There are medial meniscus is thicker posteriorly. Lateral meniscus has equal thickness between anterior and posterior portion. The peripheral red zone is vascular and might heal. The central white zone is avascular and will not heal. The blood supply comes from the geniculate arteries, which enter peripherally. Transverse ligament plus. White zone 11T-I-1L. There are two meniscofemoral ligaments, Risberg, Humphrey, which can be mimics of meniscal tears. Risberg is in the back, humping Humphrey. You could also remember that H comes before W in the alphabet. 57. Tendons. The conjoint tendon is formed by the biceps femoris tendon and the LCL. The PCL and patellar tendon may have foci of intermediate signal intensity on sagittal images with short echo time, TE, sequences, where the tendon forms an angle of 5 degrees with the main magnetic field, magic angle phenomenon. This will not be seen on T2 sequences, with long TE. This phenomenon is reduced at higher field strengths due to greater shortening OFT2 relaxation times. Magic angle. You see it on short TE sequences TL, PD, GRE. It goes away on T2. Pathology. Meniscal tears. The peripheral meniscus, red zone, has better vasculature than the inner 2/3S, white zone, and might heal on its own. Broadly you can think about tears as either vertical or horizontal. Vertical tears can be subdivided into radial and longitudinal. R. _767. Vertical, radial vertical, longitudinal horizontal. 58. L. Meniscal cysts are most often seen near the lateral meniscus, and are often associated with horizontal cleavage tears. Meniscocapsular separation, this is a rare, in real life, maybe not on exams, injury. The idea is that the deepest layer of the MCL complex capsular ligament is relatively weak and is the first to tear. This deep tearing may result in the separation of the meniscus and the MCL. I've never seen it occur in isolation, theoretically it can. Discoid meniscus, this is a normal variant of the lateral meniscus that is prone to tear. It's not C-shaped but instead shaped like a disc. In other words, it's too big, too many bow ties. Gamesmanship, pediatric patient with meniscal tear. Gamesmanship, if shown on sagittal they have to show you 3 or more bow ties, double triangles. If shown on coronal they need to show you a meniscus stretching into the notch. Baker's cyst occurs between the semimembranosus and the medial head of the gastric. Trivia, there are 3 types, with the most rare and most prone to injury being the Risberg variant. Bucket handle tear, this is a TOM meniscus, usually medial, 80%, that flips medially to lie anterior to the PCL. Gamesmanship, most likely shown as the classic and mini appearance of a double PCL. Trivia, the appearance of a double PCL can only occur in the setting of an intact ACL, otherwise it won't flip that way. Just know it sorta indirectly proves the ACL is intact. I can just see some knucklehead asking that. Discoid meniscus. Meniscus. Double PCL, bucket handle meniscal tear. Meniscal ossicle, this is a focal ossification of the posterior horn of the medial meniscus, that can be secondary to trauma or simply developmental. They are often associated with radial root tears. 59. ACL tear, ACL tears happen all the time, usually in people who are stopping and pivoting. Things to know about ACL tears, associated with Seagon fracture ACL angle lesser than Blumensaut's line O'Donoghue's unhappy triad, ACL tear, MCL tear, medial meniscal classic kissing contusion pattern, the lateral femoral condyle, sulcus terminals, bangs into the posterior lateral tibial plateau. This is 95% specific in adults. ACL tear kissing contusion pattern. ACL mucoid degeneration, this can mimic acute or chronic partial tear of the ACL. There will be no secondary signs of injury, contusion etc. It predisposes to ACL ganglion cysts, and they are usually seen together. The T2/STIR buzzword is celery stalk because of the striated look. The TL buzzword is drumstick because it looks like a drumstick. Mucoid degeneration of the ACL, drumstick celery stick. ACL repair. Method 1, using the middle 1/3 of the patellar tendon, with the patella bone plug attached to one end and tib. L. Meniscal cysts are most often seen near the lateral meniscus, and are often associated with horizontal cleavage tears. Meniscocapsular separation, this is a rare, in real life, maybe not on exams, injury. The idea is that the deepest layer of the MCL complex capsular ligament is relatively weak and is the first to tear. This deep tearing may result in the separation of the meniscus and the MCL. I've never seen it occur in isolation, theoretically it can. Discoid meniscus, this is a normal variant of the lateral meniscus that is prone to tear. It's not C-shaped but instead shaped like a disc. In other words, it's too big, too many bow ties. Gamesmanship, pediatric patient with meniscal tear. Gamesmanship, if shown on sagittal they have to show you 3 or more bow ties, double triangles.
In less than a year,
if shown on coronal they need to show you a meniscus stretching into the notch.
on Wix.
Baker's cyst occurs between the semimembranosus and the medial head of the gastric. Trivia: there are 3 types, with the most rare and most prone to injury being the Risberg variant. Bucket handle tear: this is a TOM meniscus, usually medial, 80%, that flips medially to lie anterior to the PCL. Gamesmanship, most likely shown as the classic and mini appearance of a double PCL. Trivia: the appearance of a double PCL can only occur in the setting of an intact ACL, otherwise it won't flip that way. Just know it sorta indirectly proves the ACL is intact. I can just see some knucklehead asking that. Discoid meniscus. Double PCL, bucket handle meniscal tear. Meniscal ossicle: this is a focal ossification of the posterior horn of the medial meniscus that can be secondary to trauma or simply developmental. They are often associated with radial root tears. 59. ACL tear. ACL tears happen all the time, usually in people who are stopping and pivoting. Things to know about ACL tears: associated with Seagon fracture, ACL angle lesser than Blumensaut's line, O'Donoghue's unhappy triad, ACL tear, MCL tear, medial meniscal classic kissing contusion pattern, the lateral femoral condyle, sulcus terminals, bangs into the posterior lateral tibial plateau. This is 95% specific in adults. ACL tear, kissing contusion pattern. ACL mucoid degeneration: this can mimic acute or chronic partial tear of the ACL. There will be no secondary signs of injury, contusion, etc. It predisposes to ACL ganglion cysts, and they are usually seen together. The T2/STIR buzzword is celery stalk because of the striated look. The TL buzzword is drumstick because it looks like a drumstick. Mucoid degeneration of the ACL, drumstick eye celery stick. ACL repair. Method 1, using the middle 1/3 of the patellar tendon, with the patella bone plug attached to one end and tibial bone plug attached at the other. Method 2, use a 4-strand hamstring graft often made of semitendinosus or gracilis tendon, or both. Then fold and braid the segment to form a quadruple thickness structure. Structure. The graft is then attached with interference screws, endobuttons, or staples. There is a lower reported morbidity related to harvest site using this method. Posterior lateral corner, PLC, the most complicated anatomy in the entire body. My God, this posterior lateral corner. Just think about the LCL, the IT band, the biceps femoris, and the popliteus tendon. The most likely way to show this on a single image, multiple choice style, is edema in the fibular head. Who cares? Missed PLC injury is a very common cause of a CL reconstruction failure. 60. Complications. Roof impingement: if the tibial tunnel is placed too far anterior, partially or completely anterior to the intersection of the Blumensaut line, the graft may bump up against the anterior inferior margin of the intercondylar roof. The positioning of the tibial tunnel is the primary factor in preventing impingement. Maintaining J-symmetry, isometry, is a word orthopods use to define constant length and tension of the graft during full range of motion. Positioning of the femoral tunnel is the primary factor in maintaining isometry. Arthropfibrosis can be focal or diffuse. Focal is more common. The focal form is the so-called cyclops lesion, so named because of its arthroscopic appearance. It's gonna be a low-signal speculated mass-like scar in Hoffa's fat pad. It's bad because it limits extension. Cyclops lesion, scar associated with ventral graft. Graphy tear: the graft is most susceptible to tear in the remodeling process, 4 to 8 months post-op. Signs of graft tear are increased T2 signal and fiber discontinuity. Uncovering of the posterior horn of the lateral meniscus and anterior tibial translation are considered good secondary signs. 61. PCL tear: the posterior collateral ligament is the strongest ligament in the knee. A tear is actually uncommon, but you should think about it with a posterior dislocation. Next step I association equals if you see a PCL tear, look at the popliteal flow void. If the knee dislocated posterior, a dreaded consequence is vascular compromise. Depending on the wording of the question, they might need a runoff, watch your back. Patella dislocation, dislocation of the patella, is usually lateral because of the shape of the patella and femur. The contusion pattern is classic. Things to know about patella dislocation. It's lateral. Contusion pattern classic. Associated tear of the MPFL, medial patellar femoral ligament. Associated with trochlear dysplasia, the trochlea is too flat. Meniscal flounce, this an uncommon finding of a roughied appearance of the meniscus that mimics a tear. It's not associated with an increased incidence of tear, but can look like one, if you don't have any idea what one looks like. Patella dislocation. Classic contusion pattern. 62. The foot-eye ankle. I'll lead with the most likely anatomic trivia, which is the tendons at the medial and lateral ankle. A bunch of extensor tendons no one gives a shit about tibialis anterior. 000. Peroneus longus, peroneus 8 revls. Tibia. Tibialis posterior, TOM, flexor pigitorum longus, PIC, tibial nerve flexor hall UCIs longus, hairy. Plantaris Achilles. The mythical master knot of Henry, this has a funny sounding name, therefore it's high yield. This is where Dick, FDL, crosses over Harry, FHL, at the medial ankle. What's the master knot of Henry? It's a hairy dick. 63. 63. Common pathology. Pathology seen on MRI of the ankle-eye foot. Ligamentous injury. The highest yield fact is that the anterior talofibular ligament is the weakest ligament and the most frequently injured, usually from inversion. Posterior tibial tendon injury eye dysfunction. This results in a progressive flat foot deformity, as the PTT is the primary stabilizer of the longitudinal arch. When chronic, the tear is most common behind the medial malleolus. This is where the most friction is. When acute, the tear is most common at the insertion into the navicular bone. Acute flat arch should make you think of PTT tear. You will also have a hindfoot valgus deformity from unopposed peroneal brevis action. The other point of trivia to know is that the spring ligament is a secondary supporter of the arch. It holds up the talar head, and it will thicken and degenerate without the help of the PTT. Don't get it twisted though, the spring ligament is very thick and strong and almost never ruptures in a foot/ankle trauma. I say acute flat foot, you say posterior tibial tendon injury. Classic progression, PTT out, then spring ligament out, then sinus tarsi gets jacked, then you'll strike on a painful flat foot and get plantar fasciitis. Split peroneus brevis. You can see longitudinal splits in the peroneus in people with inversion injuries. The history is usually chronic ankle pain. The tendon will be C-shaped or boomerang-shaped with central thinning and partial envelopment of the peroneus longus. Alternatively, there may be 3 instead OF2 tendons. The tear occurs at the lateral malleolus. There is a strong 80% association with lateral ligament injury. Split peroneus brevis, boomerang. Anterolateral impingement syndrome, injury to the anterior talofibular ligaments and tibiofibular ligaments, usually from an inversion injury, can cause lateral instability and chronic synovial inflammation. You can eventually produce a mass of hypertrophic synovial tissue in the lateral gutter. The MRI finding is a meniscoid mass in the lateral gutter of the ankle, which is a balled-up scar, TL and T2 dark. 64. L. Sinus tarsi syndrome, the space between the lateral talus and calcaneus. The syndrome is caused by hemorrhage or inflammation of the synovial recess, with or without tears of the associated ligaments, talocalcaneal ligaments, inferior extensor retinaculum. There are associations with rheumatologic disorders and abnormal loading, flat foot in the setting of a posterior tibial tendon tear. The MRI finding is obliteration of fat in the sinus tarsi space and replacement with scar. Normal sinus tarsi. Full of fat. Sinus tarsi syndrome. Full of scar. Tarsal tunnel syndrome, pain in the distribution of the tibial nerve, first three toes, from compression as it passes through the tarsal tunnel behind the medial malleolus. It's usually unilateral, unlike carpal tunnel, which is usually bilateral. Achilles tendon injury, acute rupture is usually obvious. The ability to plantar flex should be lost on exam, unless a plantaris muscle is intact, a common trick question. Xanthoma. Think about a xanthoma if the Achilles tendon is really enlarged, fusiform thickened. This can be seen in people with familial hypercholesterolemia, and is often bilateral. 65. Plantar fasciitis. This is an inflammation of the fascia secondary to repetitive trauma. The pain is localized to the origin of the plantar fascia, and worsened by dorsiflexion of the toes. Buzzword is most severe in the morning. Plain film might show heel spurs, MRI may show a thickened fascia, 4 mm, with increased T2 signal, most significant near its insertion at the heel. A bone scan may show increased tracer in the region of the calcaneus, from periosteal inflammation. Morton's neuroma. Soft tissue mass shown between the 3N1 and 4H metatarsal heads is most likely a Morton's neuroma, especially on multiple choice tests. They classically show it on short axis, TL, it will be dark. The proposed pathology results from compression I entrapment of the plantar digital nerve in this location by the intermetatarsal ligament. Over time this results in thickening and development of perineural fibrosis. It's a big stupid scar that looks like a dumbbell between the 3N1 and 4 metatarsals. It's usually unilateral in a woman. Plantar fasciitis. Morton's neuroma, dumbbell scar between 3rd and 4th metatarsals. Trivia: Morton's neuroma is not a neuroma, a tumor. It's a scar. 66. Section 4, Infection. With regard to osteomyelitis, radiographs will be normal for 7 to 10 days. Essentially, osteomyelitis can have any appearance, occur in any location, and at any age. Children have hematogenous spread usually hitting the long bones, metaphysis. Adults are more likely to have direct spread, in diabetic. However, you can have hematogenous spread in certain situations as well, for drugs. General rule is that septic joints are more common in adults, osteomyelitis is more common in kids. Knee jerks. Osteomyelitis in spine equals for drug user osteomyelitis in spine with kyphosis equals gibbous deformity equals TB unilateral SI joint equals for drug user psoas muscle abscess equals TB. Hallmarks are destruction of bone and periosteal new bone formation. Brody's abscess is a chronic infection, bone abscess. It's usually well circumscribed. It may have an osseous sequestrum, piece of necrotic bone surrounded by granulation tissue. As mentioned above, a sequestration has a DDX, osteomyelitis, e.g., lymphoma, fibrosarcoma. R/sequestrum. \abscess. Some frequently tested vocabulary: sequestrum equals piece of necrotic bone surrounded by granulation tissue. Ulvulcrum equals thick sheath of periosteal bone around sequestrum. Cloaca equals the space/tract where their dead bone lives. 67. Acute bacterial osteomyelitis can be thought of in three different categories: I. Hematogenous seeding, most common in child; 2. Contiguous spread; and 3. Direct inoculation of the bone either from surgery or trauma. Acute hematogenous osteomyelitis has a predilection for the long bones of the body, specifically the metaphysis, which has the best blood flow and allows for spreading of the infection via small channels in the bone that lead to the subperiosteal space. More trivia that multiple choice writers love. Age: I month equals multicentric involvement, often with joint involvement. O bone scan often negative, 75%. At this age, 18 months equals spread to epiphysis through blood. Age 2 to 16 years equals transphysial vessels are closed. Primary focus is metaphysis. In the slightly older baby, 18 months, these vessels from the metaphysis to the epiphysis atrophy and the growth plate stops the spread, although spread can still occur. This creates a septic tank effect. This same thing happens with certain cancers, leukemia. The garbage gets stuck in the septic tank, metaphysis. Once the growth plates fuse, this obstruction is no longer present. MR/findings of osteomyelitis, low signal in the bone marrow on TL imaging adjacent to an ulcer or cellulitis is diagnostic. The ghost sign: neuropathic bone vs osteomyelitis in a neuropathic bone. A bone that becomes a ghost, poor definition of margins on TL imaging. But then reappears, more morphologically distinct on T2, or after giving for contrast is more likely to have osteomyelitis. 68. Discitis/osteomyelitis. Infection of the disc and infection of the vertebral body nearly always go together. The reason has to do with the route of seeding, which typically involves seeding of the vertebral end plate, which is vascular, with subsequent eruption and crossing into the disc space, and eventual involvement of the adjacent vertebral body. Infection seeds vascular end plast, infection breaks into disc, infection crosses to other end plate. In adults, the source is usually from a recent surgery, procedure, or systemic infection. In children, it's usually from hematogenous spread. For the step 1 trivia, staph A is the most common bug, and think gram-negatives within for drug user. Almost always, 80% of the time, the ESR and CRP are elevated. Imaging. Early on it's very hard to see with plain films, you will need MRI. You are looking for paraspinal and epidural inflammation, T2 bright disc signal, and disc enhancement. Remember, gallium is superior to WBC scan in the spine. This is discussed in the neuro chapter, spine section. Pott's disease, TB of the spine, is more common in developing countries. It behaves in a few different ways, and that makes it easy to test on. Things to know about TB in LHI spine. It tends to spare the disc space. It tends to have multi-level thoracic, skip involvement buzzword, large paraspinal abscess buzzword, calcified psoas abscess buzzword, gibbous deformity, which is a destructive focal kyphosis. Mimic brucellosis, unpasteurized milk from an Amish person, can also have some disc space preservation. 69. Septic arthritis. You see this the most in large joints, which have an abundant blood supply to the metaphysis, shoulder, hip, knee. IV drug users will get it in the SJ joint and sternoclavicular joint. Conventional risk factors include being old, having AIDS, RA, and prosthetic joints. On plain film you might see a joint effusion, or MRI will show synovial enhancement. If untreated, this will jack your joint in less than 48 HOURS. Pneumoarthrogram sign. If you can demonstrate air within a joint, you can exclude a joint effusion. No joint effusion equals no septic joint. Necrotizing fasciitis. This is a very bad actor that kills very quickly. The good news is that it's pretty rare, typically only seen in ID-ver, transplant patients, diabetics, and alcoholics. It's usually polymicrobial. The second form is group A strep. Gas is only seen in a minority of cases, but if you see gas in soft tissue, this is what they want. Diffuse facial enhancement is what you'd see if ER is dumb enough to order cross-sectional imaging. They often are. Fournier gangrene is what they call it in the scrotum. TB. This is a special topic, high yield, with regard to MSK infection. It's not that common, with 5% of patients with TB having MSK involvement. Although on multiple choice tests, I think you'll find it appears with a high frequency. Key points to know: the vertebral body is involved with sparing of the disc space until late in the disease, very different than more common bacterial infections. Gibbous deformity is a focal kyphosis seen in Pott's disease, among many other things. Rice bodies. These are sloughed, infarcted synovium seen, with end-stage RA, and TB infection of joints. Tuberculosis dactylitis, spina ventosa, typically affects kids more than adults with involvement of the short tubular bones of the hands and feet. It is often a smoldering infection without periosteal reaction. Classic look is a diaphyseal expansal lesion with soft tissue swelling. 70. Section 5. Aggressive lesions. There are tons of primary osseous malignancies. The most common are myeloma/plasmacytoma, 27%, osteosarcoma, 20%, and chondrosarcoma, 20%. According to Helms, the wide zone of transition is the best sign that a lesion is aggressive. This is actually a useful pearl. Myeloma I plasmacytoma, I METS, discussed in the cystic bone lesion section. Osteosarcoma. There are a bunch of subtypes, but for the purpose of this discussion there are 4. Conventional intramedullary, 85%, parosteal, 4%, periosteal, 1%, telangiectatic, rare. All the subtypes produce bone, or osteoid from neoplastic cells. Most are idiopathic, but you can have secondary causes, usually seen in elderly, XRT, Paget's, infarcts, etc. Conventional intramedullary, more common, and higher grade than the surface subtypes, periosteal, and parosteal. Primary subtypes typically occur in young patients, 10 to 20. The most common location is the femur, 40%, and proximal tibia, 15%. Buzzwords include various types of aggressive periosteal reactions. Sunburst periosteal reaction that is aggressive and looks like a sunburst Cadman triangle, with aggressive lesions, the periosteum. I does not have time to ossify completely with new bone, e.g. as seen in single-layer and multi-layered periosteal reaction, so only the edge of the raised periosteum will ossify, creating the appearance of a triangle. Lame/lated, onion skin reaction, multi-layers of parallel periosteum, looks like an onion skin. High-yield trivia, pathologic fracture at risk. Osteosarcoma met to the lung is a classic, frequently tested, cause of occult pneumothorax. Reverse zoning phenomenon, more dense mature matrix in the center, less peripherally, opposite of myositis ossificans. 0 at. Progress over time, reverse zoning equals bad. Reasons to be concerned include 1. Lytic lesions. 2. Lesions 3 cm in size. 3. Lesions involving more than 50% of the cortex. These measurements are CT or plain film, not MRI. 71. Parosteal osteosarcoma, generally low-grade, bulky parosteal bone formation. Think big, just say big. This guy loves the posterior distal femur. Because of this location it can mimic a cortical desmoid early on. The lesion is metaphyseal 90% of the time. The buzzword is string sign, which refers to a radiolucent line separating the bulky tumor from the cortex. Periosteal osteosarcoma worse prognosis than parosteal, but better than conventional osteosarcoma. Tends to occur in the diaphyseal regions, classic medial distal femur. PLE vs TL1A1, paroscal vs preoscal oscosarcoma parosteal periosteal early adult middle age group, 15 to 25, metaphysis, 90%. Diaphyseal likes posterior distal femur, likes medial distal femur marrow extension, 50%. Low grade. Telangiectatic osteosarcoma, about 15% have a narrow zone of transition. Fluid levels on MRI is classic. They are high on TL, from methemoglobin. Can be differentiated from ABC, or GCT, maybe, by tumor nodularity and enhancement. Usually no marrow extension intermediate grade. Flu1D levels DDX. Telangiectatic osteosarcoma aneurysmal bone cyst giant cell tumor. Osteoarcoma subtype. Parosteal periosteal telangiectatic classic, ultramedullary, secondary OS started off as Pagels. 72. LL. Chondrosarcoma. Chondrosarcoma, usually seen in older adults. Adults, MF. Likes flat bones, limb girdles, proximal tubular bones. Can be central, intramedullary, or peripheral, at the end of an osteochondroma. Most are low grade. Risk factors, Pagets and anything cartilaginous, osteochondromas, Mafuchis etc. Gamesmanship, if shown with CT, they have to show you some chondroid matrix, arcs and rings. Gamesmanship, if you want to say chondroblastoma, but it's an adult, think clear cell chondrosarcoma. This vs that, enchondroma vs low-grade chondrosarcoma. Factors favoring chondrosarcoma. Pain, cortical destruction, scalloping of 2/3 of the cortex, 5 cm in size, changing matrix. Ewing's, permeative lesion in the diaphysis of a child equals Ewing's, could also be infection, or e.g. Extremely rare in African Americans. Likes to met bone-to-bone, skip lesions are more common in Ewing's, relative to osteosarcoma. Does not form osteoid from tumor cells, but can mimic osteosarcoma because of its marked sclerosis. Sclerosis occurs in the bone only, not in the soft tissue, which is not the case in osteosarcoma. Chondroma usually seen in adults, 30 to 60, usually slightly younger in the clivus and slightly older in the sacrum. Most likely questions regarding the chondroma include location, most common sacrum, second most common clivus, third most common vertebral body, and the fact that they are very T2 bright. Chondroma most commons. Most common primary malignancy of the spine. Most common primary malignancy of the sacrum. When involving the spine, most common at C2. I say chondroma, you say midline, midline, midline. Why is it always midline? It's made of cells left over from the notochord, some embryology bullshit that was involved in making midline structures. Chondromas are never ever seen off the midline ever in the hip, leg, arm, hand, etc. 73. Section 6. Soft tissue masses. Studying learning MSK soft tissues masses tumors tend to create tons of anxiety. This is because academic radiology tend to overcomplicate the issue. Here is the simple part, only about 20 to 30% of them can be accurately diagnosed on MRI. That's because they are almost all T2 bright and enhance. This is actually good news for the purpose of multiple choice, because you only need to learn the ones that don't behave like that, or are overwhelming likely due to epidemiological stats, which has to be provided for you either the patient is 65, or with clues, arthritis equals old, no arthritis equals not old. Here is the list I would know. MFH, malignant fibrous histiocytoma, aka, pleomorphic undifferentiated sarcoma synovial sarcoma lipoma, atypical lipoma, liposarcoma hemangioma myxoma. Malignant fibrous histiocytoma, MFH. Yes, they changed the name to pleomorphic undifferentiated sarcoma pus. However, I want you to continue to think of this as MFH because it will help you remember some of the imaging features. First, the generalizations, this is very common. It's seen in old people. It's seen in a central location, proximal arms and legs. Features, about half the time it's dark to intermediate on T2, remember most soft tissue tumors are T2 bright. The way I remember this is the word fibrous makes me think scar, which is dark. Gamesmanship, these things are often associated with spontaneous hemorrhage, they outgrow their blood supply. The history is often old lady, stood up from a chair, has a big proximal muscular hematoma, under that hematoma is the MFH. Trivia, bone infarcts can come into MFH, sarcoma 2 transformation of infarct. Trivia, radiation is a risk factor. 74. L. Synovial sarcoma. Generalization, seen most commonly in the peripheral lower extremities of patients aged 20 to 40. Gamesmanship, they occur close to the joint, but not in the joint. To confuse the issue they may have secondary invasion into the joint, 10%, however for the purpose of multiple choice tests, they never involve the joint. A common trick is to show an ultrasound of the leg with looks like a Baker's cyst, but the motherfucker is too complex, or has flow in it. Asterisk, not everything in the popliteal fossa is a Baker's cyst, especially on multiple choice. Baker's cyst fuckery. Barker's cyst must be located between the medial head of the gastrocnemius and the semimembranosus. If it's not, you should think synovial sarcoma, and next step MRI. Besides the not a Baker's cyst trick, there are 3 other ways to show this. 1 as the triple sign, which is high, medium, and low signal AJL in the same mass probably in the knee on T2, 2 as the bowl of grapes, which is a bunch of fluid levels in a mass probably in the knee, or 3, as a plain X-ray with a soft tissue component and calcifications, this would be the least likely way to show it. Synovial sarcoma trivia. Most sarcomas don't attack bones, synovial sarcoma can. Most sarcomas present as painless mass, synovial sarcomas hurt soft tissue calcifications, and bone erosions are highly suggestive. They are slow-growing and small in size, often leading to people thinking they are benign. 90% have a translocation of X18. Most common malignancy in teens/young adults of the foot, ankle, and lower extremity. When I say ball-like tumor in the extremity of a young adult, you say synovial sarcoma. When I say Safi tissue tumor in the foot of a young adult, you say synovial sarcoma. MFH, pus. Synovial sarcoma. Al Wu. Dash dash a dash. Dash a dash a dash dash. Dash a dash. Dash dash a dash 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 a dash a dash. Lipoma vs. atypical lipoma vs. liposarcoma. These exist on a spectrum, with lipoma being totally benign, and liposarcoma being a bad boy. A pearl is that histologically atypical lipoma behaves, and looks just like a low-grade liposarcoma. It would be total horseshit to ask you to tell those apart. It's more likely the distinction will be either lipoma vs. liposarcoma. Think about them like this. Lipoma I. J signal intensity parallels fat on all sequences. Will fat sad out? Atypical lipoma, I low-grade liposarcoma. May have parts that are slightly darker or brighter than fat on T1. May incompletely fat sat. No septations or thin ones, L thick junky septations. Pearls. IIL. Liposarcomas tend to be deep, retroperitoneum, lipomas tend to be superficial, liposarcomas tend to be big. High-grade liposarcoma, the one that fucks you up, may not even have fat. For the exam it will have some, otherwise you can't even tell for sure that it is a liposarcoma. May incompletely fat sat, or not fat sat at all, thick nodular complex stuff enhancing components. Trivia, myxoid liposarcoma is the MC liposarcoma in patients 20. They can be T2 bright expected, but TL dark confusing, don't call it a cyst. Also, don't call it a comeback, I've been here for years. They'll need GAD plus. 76. L. Hemangioma. These are common. Here are the tricks. Lipoma I. J signal intensity parallels fat. L. Hemangioma. These are common. Here are the tricks. T2 bright, like most tumors, flow voids. They have to show you flow voids, bunch of dark holes. Hemangiomas don't respect fascia boundaries, they will infiltrate into stuff, this is a somewhat unique features. Enhances intensely, they are a vascular tumor, they can contain fat, and likely will on multiple choice. Next step, a great next step question would be to ask for a plain film. Why a plain film? Phleblets, my friend, if they show you soft tissue phleblets then hemangioma is the answer. Myxoma. If this shows up on the exam it is almost certainly going to be shown in the setting of Mazabrod syndrome. WTF is Mazabrod syndrome? It's a totally zebra syndrome, which makes it totally appropriate for an intermediate level exam. It has 3 main findings. 1. Polyostotic fibrous dysplasia, which makes you ugly. 2. Multiple soft tissue myxomas. 3. An inability to get a date to the prom. *C finding L. What do myxomas look like? They are T2 bright, like every tumor, but tend to be lower signal than muscle on TL, which makes them sorta unique. 77. Treatment high yields. Osteosarcoma, chemo first to kill micromets, followed by wide excision. Ewings, both chemo and radiation, followed by wide excision. Chondrosarcoma, usually just wide excision, they are usually low grade, and main concern is local recurrence. Giant cell tumor, because it extends to the articular surface, usually requires arthroplasty. J. Don't touch lesions, characteristically benign lesions, that look aggressive but are T, and should not be biopsied because of possibly misleading pathology. I. Circumferential I can look scary on MRI if M.T. 0. Synovial herniation pitaracteristic location in I-Pit's pit, ephemeral neck dash dash dash. Dash a dash dash. Bone biopsy. Ilytic appearing lesion, Li dash dash J. The route of biopsy should be discussed with the orthopedic surgeon. To avoid contin 1 in adding compartments not involved by the lunar, or not going low be used in the resection process. Special considerations, pelvis, avoid crossing gluteal muscles, may be needed for reconstruction. Knee, avoid the joint space via crossing suprapatellar bursa, or other communicating bursae. Avoid crossing the quadriceps tendon unless it is involved. Shoulder, avoid the posterior 213 RD, axillary nerve courses post, anterior, therefore a posterior resection will denervate the anterior 113. 78. L. Section 7. Lucent lesions. Lesions. Phygnomachic is the mnemonic for lucent bone lesions made popular by Clyde Helms. As it turns out, you can rearrange the letters of phygnomachic to form a word fog machines. I find it a lot easier to remember a mnemonic if it actually forms a real word. Having said that, the whole idea of memorizing a list of 11 or 12 things is really stupid. You would never give a differential that included all of those. They occur in different places, in different ages, and often look very different. Differentials, for people who know what they are looking at, are usually never deeper than 3 or 4 things. If you are giving a differential of 12 things, just say you don't know what it is. For multiple choice, when you encounter a lucent bone lesion, you can expect one of two questions: 1, what is it? Or 2, what is IJ associated with? In either case, you are going to need to figure out what it is. In the real war JD, you would probably have to give a short differential, but in the world of multiple choice, you will have to come up with one answer. Don't fret, they have to give you clues so you can pick just one. A useful mental exercise when eliminating multiple choice distractors is to ask yourself, why is it not this? It's an exercise that is often not performed at the workstation, but very valuable in the test environment, especially for these types of questions. Here is my suggested method. 1. Figure out the age of the patient. If you are lucky, they will tell you. If you are less lucky, you will have to guess. Growth plates open equals kid. Growth plates closed with no degenerative change equals young adult. Growth plates closed with degenerative changes equals older than 40. Age, the key to remember is that 30 equals e.g., ABC, NOF chondrolastoma, and solitary bone cysts. Any age equals lympheclion. Greater than -40 equals Mets and myeloma, unless it /neurolastoma Mets. 2. Location of the lesion. Metaphysis, epiphysis, diaphysis. Is this an equivalent discussion? See the next page for discussion. 3. Classic locations and looks. See my summary of these on page 88. 79. Location. Epiphysis, R dash 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 R dash 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 R dash 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 R dash 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 1. In general, only a few lesions tend to arise in the epiphysis. The four horsemen of the epiphyseal equivalents. Big ones to remember. Remember are the carpals, the patella, the greater trochanter and the calcaneus. Apophysis is the mnemonic I like to use, and I think about the company AIG that was involved in some scandal a few years ago. AIG, the evil company. ABC, infection, giant cell, and chondroblastoma. Asterisk, the caveat is that ABC is usually metaphyseal, but after the growth plate closes it can extend into the epiphysis. For the purpose of multiple choice tests it is important to not forget about the malignant tumor at the end of the bone, epiphysis, clear cell chondrosarcoma. This guy is slow-growing, with a variable appearance, lytic, calcified, lobulated, ill-defined, etc. Just remember if they say malignant epiphyseal you say clear cell chondrosarcoma. Metaphysis. The metaphysis is the fastest-growing area of a bone, with the best blood supply. This excellent blood supply results in an increased predilection for mets and infection. Most of the cystic bone lesions can occur in the metaphysis. Diaphysis. Just like the metaphysis, most entities can occur in the diaphysis, they just do it less. 80. L. Pathology for trivia. Fibrous dysplasia. Fibrous dysplasia is a skeletal developmental anomaly of osteoblasts, failure of normal maturation and differentiation. The disorder can occur at any age. It can be monostotic, 20s and 30s, or polyostotic, 10-year-old. Famously has a very variably appearance, with phases like Paget's, lytic, mixed, blastic. The buzzword is ground glass. The catchphrase is long lesion in a long bone. The textbook appearance, lytic lesion with a hazy matrix, the discriminator used by Helms, is no periosteal reaction or pain. Likes the ribs and long bones. If it occurs in the pelvis, it also hits the ipsilateral femur, shepherd crook deformity. If it's multiple it likes the skull and face, lion-like faces. THIVS that, McCune-Albright vs Mazabrod syndrome, McCune-Albright Mazabrod. Polyostotic. Polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia. Girl, woman, middle-aged, café au lait spot, soft tissue myxomas. Myxomas. Precocious puberty, increased risk, osseous malignant transformation. Adamantinoma, a total zebra, probably a unicorn. A tibial lesion that resembles fibrous dysplasia, mixed lytic and sclerotic. It is potentially malignant. Enchondroma. This guy is a tumor of the medullary cavity composed of hyaline cartilage. It appears as a lytic lesion with irregularly speckled calcification of chondroid matrix, classically described as arcs and rings. Having said that the spondroid matrix is not found in the fingers or toes, this is a high-yield factoid for the purpose of multiple-choice tests. The enchondroma is actually the most common cystic lesion in the hands and feet. Just like fibrous dysplasia, this lesion does not have periostitis. Humerus or femur equals rings, and arcs fingers or toes equals lytic. The trick to differentiating enchondroma vs a low-grade chondrosarcoma is the history of pain. 81. Eosinophilic granuloma, e.g. this is typically included in every differential for people less than 30. It can be solitary, usually, or multiple. Monostotic, 20s. Eosinophilic granuloma, e.g. this is typically included in every differential for people less than 30. It can be solitary, usually, or multiple. There are 3 classic appearances, for the purpose of multiple choice. 1. Vertebra plana in a kid. 2. Skull with lucent beveled edge lesions, also in a kid. 3. Floating tooth, with lytic lesion in alveolar ridge, this would be a differential case. The appearance is highly variable and can be lytic or blastic, with or without a sclerotic border, and with or without a periosteo response. Can even have an osseous sequestrum. Classic deeks for vertebra plana, MELT, metzimyeloma e.g. lymphoma trauma/TB. Classic deeks for osseous sequestrum, osteomyelitis lymphoma, fibrosarcoma, e.g. osteoid osteoma can mimic a sequestrum. Giant cell tumor, GCT. This guy has some key criteria, which lend themselves well to multiple choice tests. They include, physis must be closed, non-sclerotic border abuts the articular surface. Another trick is to show you a pulmonary met and ask if it could be OT. The answer is yes, although this is rare. GCT is considered quasi-malignant because they can be locally invasive and about 5% will have pulmonary mets, which are still curable by resection. As a result of this, they should be resected with wide margins. Things low know about GCTs, most common in the knee, abutting the articular surface, most common at age 20 to 30. Physis must be closed. There is an association with ABCs. They can tum into them. They are quasi-malignant. 5% have lung mets. Fluid levels on MRL 82. F. L. Nonosifiing fibroma, NOF. These are very common. They are seen in children and will spontaneously regress, becoming more sclerotic before disappearing. They are rare in children not yet walking. Just like GCTs, they like to occur around the knee. They are classically described as eccentric with a thin sclerotic border. Remember, GCTs don't have a sclerotic border. They are called fibrous cortical defects when smaller than 2 centimeters. Vocab, NOFs are the larger version, 3 cm, of a fibrous cortical defect, FCD. A wastebasket term for the both of them is simply fibroxanthorna. LR Jafkamp-Axi syndrome, syndrome of multiple NOFs, cafe spots, mental retardation, hypogonadism, and cardiac malformations. Osteoid osteoma, pain at night, relieved by aspirin. It's classically found in 2 spots, 1, meta/diaphysis of long bones, and 2, the posterior elements of the spine. One way to test this is to show a plain film that is probably an osteoid osteoma, then follow it with an MRI showing lots of edema. I'll say that again, large amount of edema for the size of the lesion. Another piece of trivia is that when you have them in the spine, most common in the lumbar spine, you frequently have an associated painful scoliosis with the convexity pointed away from the lesion. These can be treated with percutaneous radiofrequency ablation, as long as it's not with an LCM of a nerve or other vital structure, typically avoided in hands, spine, and pregnant patients. Association of osteoid osteoma. Underscore equals L painful scoliosis underscore. Underscore 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 underscore. Aneurysmal bone cyst. ABC aneurysmal bone cysts are aneurysmal lesions of bone with thin-walled, blood-filled spaces, fluid level on MRI. Patients are usually 30. They may develop following trauma. Location, tibia, vert, femur, humerus. They can be described as primary ABC, presumably arising de novo, or secondary ABC, associated with another tumor, classic GCT. They are commonly associated with other benign lesions. Things low knowable ABC. Classic DDX for lucent LESIO11 in posterior elements osteoblastoma, ABC-TB. Up to 40% of secondary ABCs are associated with giant cell tumor of bone. It's on the DDX for fluid level on MRI patient 30 tibia is the most common site. Solitary, unicameral, bone cyst. It would be unusual to see one of these in a patient older than 30. Most common in the tubular bones, 90 to 95%, usually humerus or femur. Unique feature, always located centrally. It's going to be shown one of Of two ways, one, with a fracture through it in the humerus, probably with a fallen fragment sign, or a 2, as a lucent lesion in the calcaneus, probably with a fallen fragment sign. The fallen fragment sign, bone fragment in the dependent portion of a lucent bone lesion, is pathognomonic of solitary bone cyst. Brown tumor, hyperparathyroidism. The brown tumor represents localized accumulations of giant cells and fibrous tissue, in case someone asks. They appear as lytic or sclerotic lesions with other findings of hyperparathyroidism, subperiosteal bone resorption. In other words, they need to tell you he/she has hyperparathyroidism first. They may just straight up tell you, or they will show you some bone resorption first, classically on the side of a finger, edge of a clavicle, or under a rib. These things have different stages of healing sclerosis. They resorb and can become totally sclerotic/healed when the hyper-PTH is treated. // L. Chondroblastoma. This is seen in kids, 90% age 5 to 25. They classically show it in two ways, one, in the epiphysis of the tibia on a 15-year-old, or two, in an epiphyseal equivalent. So what are the epiphyseal equivalents? Patellocalcaneus carpal bones and all the apophyses, greater and less trochanter, tuberosities, etc. Features of the tumor include Include a thin sclerotic rim, extension across the physial plate, 25 to 50%, periostitis, 30%. Actual location, femur, humerus, tibia. This may show bone marrow edema and soft tissue edema on MRI. MRI can mislead you into thinking it's a bad thing. This is one of the only bone gamesmanship hip. When you have a chondroblastoma in the hip, it tends to favor the greater trochanter. Trochanter, more than the femoral epiphysis. Chondromyxoid fibroma, this is the least common benign lesion of cartilage. It is usually in patients younger than 30. The typical appearance is osteolytic, elongated in shape, eccentrically located, metaphyseal lesion, with cortical expansion and a bite-like configuration. Sorta looks like a NOF. The hip. Greater trochanter, remember this is also an epiphyseal equivalent and the chondroblastomas prefer it to the femoral epiphysis. You can get all the other DDXS, ABC, infection, GCT here as well. Plus, you can have avulsions of the gluteus medius and minimus. Lesser trochanter, an avulsion here, without significant clinical history, should make you think pathologic fracture. The intertrochanteric region, classic DDX here, lipoma, lipoma, solitary bone cyst, and monostotic fibrous dysplasia. The calcaneus. There are several classic lesions that can be shown in the calcaneus. There are also several non-classic lesions that can be shown, sneaky things. The classic 3. Solitary bone cyst, this will have sharp edges. A thick sclerotic edge with a multiloculated appearance is helpful. The fallen fragment will be more in the bottom if shown, although fractures in the calcaneus are much less common than in the an. Pseudocyst, this is a variation on the normal trabecular pattern, which creates a central triangular radiolucent area. Supposedly the persistence of thin trabeculae and visible nutrient foramen, along with the classic location, are helpful in telling it from the other benign entities. Pseudocyst. Oncroceous lipoma, if they show you this, it will either have to have A. Fat density on CT or MRI, or B. A central fragment stuck within the middle of the fat. This calcification I fat necrosis occurs about 50% of the time in the real world. Sneaky things. Just remember that the calcaneus is an epiphyseal/equivalent, so ABC, infection, GCT, and spudroblastoma can all occur there. Think about these when the lesion is more posterior. In the setting of subtalar degenerative change, you can get a geode that mimics a cystic lesion. Think about this in older patients, 60s, with obvious arthritis. Some random benign lesion differentials. No periostitis or pain, fibrous dysplasia, enchondroma, NF, solitary bone cyst, unless fractured. Multiple, FEMI. Fibrous dysplasia, e.g. enchondroma, Metz I myeloma, hyperparathyroidism. 86. L. Dot underscore underscore. Metastatic disease should be on the differential for any patient over 40 with a lytic lesion. As a piece of trivia, renal cancer is always lytic, usually. Classic elastic lesions, prostate, carcinoid, medulloblastoma. Classic lytic lesions, renal and thyroid. Next step: prostate met vs bone island. Get a bone scan. Bone island should be mild or not active, prostate met should be hot. Multiple myeloma. Myeloma, plasma cell proliferation. Proliferation increases surrounding osteolytic activity, in case someone asks you the mechanism. Usually an older patient, 40s to 80s. Plasmacytomas can precede clinical or hematologic evidence of myeloma by 3 years. They usually have discrete margins and can be solitary or multiple. Vertebral body destruction with sparing of the posterior elements is classic. Bone scan is often negative, skeletal survey is better, but horrible pain to read, and MRI is the most sensitive. Additional classic, testable scenario, manifesting as diffuse osteopenia. Myeloma-related conditions. Plasmacytoma, usually under 40. This is a discrete, solitary mass of neoplastic monoclonal plasma cells in either either bone or soft tissue, extraangulary subtype. It is associated with latent systemic disease in the majority of affected patients. It can be considered as a singular counterpart multiple myeloma. The lesions look like a geographic lytic area, sometimes with expansal remodeling. Mini brain appearance plasmacytoma in vertebral body. Poems, this is basically myeloma with sclerotic mets. It's a rare medical syndrome with plasma cell proliferation, typically myeloma, with neuropathy and organomegaly. 87. 87. Long lesion in a long bone equals fibrous dysplasia, ground glass equals fibrous dysplasia chondroid matrix in the proximal humerus, or distal femur equals enchondroma lucent lesion in the finger, or toe equals enchondroma s epiphyseal tibial lesion in a teenager equals chondroblastoma, epiphyseal equivalent lesion equals chondroblastoma, or giant cell tumor. One lucent lesion in the greater trochanter equals chondroblastoma. A lucent lesion with a fracture, fallen fragment, in the humerus equals solitary bone cis CL/calcaneal lesion with central calcification equals lipoma /0 lucent lesion in the skull equals EG/vertebra plana in kid equals EG/vertebra plana in an adult equals met sequestrum initis in the tibia, I femur equals osteoid osteoma/T. Painful scoliosis equals osteoid osteoma JS calcified lesion in the posterior element of the C-spine equals osteoblastoma. 88. Section 8. Miscellaneous topic. Liposclerosing myxofibroma, re-characteristic location, at the intertrochanteric region of the femur. Looks like a geographic lytic lesion with a sclerotic margin. Despite non-aggressive appearance, 10% undergo malignant degeneration, so they need to be followed. Osteochondroma. Some people think of this as more of a developmental anomaly, although they still always make the tumor chapter. Actually, it's usually listed as the most common benign tumor. They can be radiation-induced, making them the only benign skeletal tumor associated with radiation. They have a very small risk of malignant transformation, which supposedly can be estimated based on size of cartilage cap. Supposedly a cap, L.5 cm is concerning. Key points: they point away from the joint, the bone marrow flows freely into the lesion. Multiple hereditary exostoses, AD condition with multiple osteochondromas. They have an increased risk of malignant transformation. Trevor disease, dysplasia epiphysealis hemimelica. De osteochondromas develop in an epiphysis causing significant joint deformity, most common in ankle and knee. You see this as young children. The osteochondroma looks more like an irregular mass. They tend to be treated with surgical excision. Supracondylar spur, avian spur. This is an ant mini and normal variant. This is an osseous process that usually does nothing, but can compress the median nerve if the ligament of Struthers smashes it. This or that, osteochondroma vs supracondylar spur. Osteochondroma supracondylar spur. Points away from joint, points toward the joint. 89. Periosteochondroma, juxtacortical chondroma. When you see a lesion in the finger of a kid, think this. It's a rare entity or cartilaginous origin. Saucerization of the adjacent cortex with sclerotic periosteal reaction can be seen. Osteofibrous dysplasia. This is a benign lesion found exclusively in the tibia or fibula in children 10 and under usually. It looks like an NOF but centered in the anterior tibia, with associated anterior tibial bowing. It can occur with adamantinoma, and the two cannot be differentiated with imaging. When I say looks like NOF in the anterior tibia with anterior bowing, you say osteofibrous dysplasia. Tibial bowing. Most likely shown as an ant mini, NF, one anterior with a fibular pseudoarthrosis, rickets with wide growth plates, or Blount's tibia vara. The most likely pure trivia question is that physiology bowing is smooth, lateral, and occurs from 1b months, 2 years. // INF, 1 SEC110N9, Arthritis. Arthritis is tricky. And Brower wrote a book called Arthritis in Black and White, which is probably the best book on the subject. The problem is that book is 415 pages. So I'm going to try and offer the 10-page version. Epidemiology. Although there are over 90 different rheumatic diseases recognized by the American College of Rheumatology, only a few tend to show up on multiple-choice tests, and at the view box. You can broadly categorize arthritis into 3 categories: DIA degenerative, OA, neuropathic, 2 inflammatory, RA, and variants, QJ metabolic, gout, CPPD. Degenerative. Osteoarthritis is the first common cause. The pathogenesis is that you have mechanical breakdown, hard work, which leads to cartilage degeneration, fissures, microfractures, and fragmentation of subchondral bone, sclerosis, and subchondral cysts. You get all the classic stuff: joint space narrowing, OT semi-euandral cysts, end plate changes, vacuum phenomenon, etc. The poster boy is TH. Neuropathic joint. The way the case is classically shown is a bad joint followed by the reason for a bad joint, syringomyelia, spinal cord injury, etc. A way to think about this is osteoarthritis with a vengeance. The buzzword is surgical, like F'. 3 by 1, basically nothing else causes this kind of destruction. I like to describe the joints as a deformity, with debris and dislocation, having dense subchondral bone, and destruction of the articular cortex. The classic scenario is a shoulder that looks like it's been amputated, and then they show you a syrinx. 91. Inflammatory. Erosive osteoarthritis, inflammatory osteoarthritis. The buzzword is gull wing, which describes the central erosions. It is seen in postmenopausal women and favors the dip joints. Erosive OA gullwing. Rheumatoid arthritis. There is a ton of trivia related to this disease. It's not a disease of bone production. Instead, it is characterized by osteoporosis, soft tissue swelling, marginal erosions, and uniform joint space narrowing. It's often bilateral and symmetric. Classically spares the dip joints, opposite of erosive OA. Trivia. The 5th metatarsal head is the first spot in the foot. RA in the hand pearls. Expect the IP joints, PIP, to be involved after the MCP joints. The first CMC is classically spared, or is the last carpal to be involved. The first CMC should not be first. Obviously OA loves the first CMC, so this is helpful in separating them. Psoriasis, on the other hand, also tends to make the first CMC go last. Felty syndrome, RA, 10 years, and splenomegaly and neutropenia. Kaplan syndrome, RA, and pneumoconiosis. The distribution of RA vs OA in the hip is a classic teaching point. Axial. RA. 92. Rheumatoid variants. Psoriatic arthritis, Reiter's syndrome, reactive arthritis, ankylosing spondylitis, inflammatory bowel disease. Psoriatic arthritis. This is seen in 30% of patients with psoriasis. In almost all cases, 90%, the skin findings come first, then you get the arthritis. As a point of trivia, there is a strong correlation between involvement of the nail and involvement of the dip joint. The classic description is erosive change with bone proliferation, IP joints, MCP joints. The erosions start in the margins of the joint and progress to involve the central portions, can lead to a pencil sharpening effect. The hands are the most commonly affected, second most common is the feet. Up to 40% of cases will have SI joint involvement, asymmetric. Additional buzzwords. Fuzzy appearance to the bone around the joint, bone proliferation, sausage digit, whole digit has soft tissue swelling, ivory phalanx, sclerosis and slash or bone proliferation, most commonly the great toe, pencil and cup deformities, ankylosis in finger, mouse ears, acroosteolysis. IP joints, ray pattern, pencil and cup. When I say ankylosis in the hand, you say 1. Erosive OA or 2. Psoriasis. RA psoriasis symmetric, asymmetric proximal, favors MCP, carpals, distal, favors IP joints, osteoporosis, no bone proliferation, the form of rheostitis lean cause mutilans when severe can cause mutilans when severe. Mouse ears. 93. Reiter's, reactive arthritis. Apparently Reiter was a Nazi, killed a bunch of people with typhus vaccine experiments. So people try not to give him any credit for things, hence the name changed to reactive arthritis. Regardless of what you call it, it's a very similar situation to psoriatic arthritis, both have bone proliferation and erosions, and asymmetric SI joint involvement. The difference is that Reiter's is rare in the hands, tends to affect the feet more. Just remember Reiter's below the waist. You know who else was a Nazi? Henry Ford. Google it. Ankylosing spondylitis. This disease favors the spine and SI joints. The classic buzzword is bamboo spine. Spine, from the syndesmophytes flowing from adjacent vertebral bodies. Shiny corners is a buzzword for early involvement. As you might imagine, these spines are susceptible to fracture and trauma. SI joint involvement is usually the first site, symmetric. The joint actually widens a little before it narrows. As a point of trivia, these guys can have an upper lobe predominant interstitial lung disease, with small cystic spaces. Next step, any significant ankh-spawn IDISH plus even minor trauma equals whole spine CT. Random high-yield topic, ankylosing spondylitis in the hip. When the peripheral skeleton is involved in patients with ankh-spond, think about the shoulders and hips more common. Hip involvement can be very disabling. Heterotopic ossification tends to occur post-hip replacement or revision. LT occurs so much that they often get postoperative low-dose radiation and NSAIDs to try as prophylactic therapy. If they show you normal SI joints, then show you anything in the spine if not as. It has to hit the SI joints first, especially on multiple choice. Inflammatory bowel disease. This occurs in two distinct flavors. A. Axial arthritis, favors SI joints and spine, often unrelated to bowel disease. B. Peripheral arthritis. This one varies depending on the severity of the bowel disease. 94. L. RL_L. Unilateral equals infection. R. Psoriatic arthritis. Asymmetric equals psoriasis, Reiter's. Reiter's, reactive, FMF. I. Asymmetric SI joint hands, feet, thoracolumbar spinage feet, lumbar spine, SI joint. Metabolic. Symmetric equals inflammatory bowel, A5. Ankylosing spondylitis M, F. Symmetric SI joint, spine, whole thing. Gout. This is a crystal arthropathy from the deposition of uric acid crystals in and around the joints. It's almost always in a man over 40. The big toe is the classic location. Buzzwords I things to know. Earliest sign equals joint effusion spares the joint space, until late in the disease, JMTA articular erosions, away from the joint. Punched out lytic lesions, overhanging edges, soft tissue tophi. Gout on MR. Juxtaarticular soft tissue masse, low on T2. The tophus will typically enhance. Gout mimickers. There are 5 entities that can give a similar appearance to a gouty arthritis, although they are much less common. The way I remember them is American Röntgen Ray Society. Hooray, amyloid RA, cystic, reticular/lymphocytosis, the most rare, sarcoid hyperlipidemia. 95. CPPD, calcium pyrophosphate dihydrate disease, is super common in old people. It often causes chondrocalcinosis, although there are other causes. Synovitis plus CPPD equals pseudogout. CPPD loves the triangular fibrocartilage of the wrist, the periodontoid tissue, and intervertebral discs. Another important phrase is degenerative change in an uncommon joint: shoulder, elbow, patellofemoral joint, radiocarpal joint. Having said that, pyrophosphate arthropathy is most common at the knee. If you see isolated disease in the patellofemoral, radiocarpal, or talonavicular joint, think CPPD. Hooked MCP osteophytes with chondrocalcinosis in the TFCC is a classic look, although hemochromatosis can also look that way. Remember, CPPD can, and does commonly, cause SLAC wrist by degenerating the SL ligament. OA vs CPPD. There are many overlapping features, including joint space narrowing, subchondral sclerosis, subchondral cyst, and osteophyte phonation. However, CPPD has some unique features such as an atypical joint distribution, favoring compartments like the patellofemoral or radiocarpal. Subchondral cyst formation can be bigger than expected. Hemochromatosis. This iron overload disease also is known for calcium pyrophosphate deposition and resulting chondrocalcinosis. It has a similar distribution to CPPD, MCP joints. Both CPPD and hemochromatosis will have hooked osteophytes at the MCP joint. This vs that CPPD and hemochromatosis. Hemochromatosis has uniform joint space loss at all the MCP joints. CPPD favors the index and middle finger MCPs. Trivia. As a point of trivia, therapy for the systemic disease does not affect the arthritis. Hooked osteophytes, CPPD vs hemochromatosis. 96. Hyperparathyroidism. As you may remember from medical school, this can be primary or secondary, and its effects on calcium metabolism typically manifest in the bones. Here are your buzzwords: subperiosteal bone resorption of the radial aspect, second and third fingers, Rugger Jersey spine, brown tumors, terminal tuft erosions. The classic ways this is shown: superior and inferior rib notching, bone resorption along the radial aspect of the thigh, Engers with brown tumors, tuft resorption, Rugger Jersey spine, pelvis with narrowing or constricting of the femoral necks, and wide SI joints. Hyperparathyroidism. Subperiosteal resorption, tuft resorption, and brown tumors, Rugger Jersey spine, brown tumor. Milwaukee shoulder. This is a destruction of the shoulder, almost looks neuropathic, but is secondary to hydroxyapatite. The articular surface changes will be very advanced, and you have a lot of intra-articular loose bodies. It's classically seen in an old woman with a history of trauma to that joint. 97. Problem solving. If you are given a picture of a hand or foot and asked what the arthritis is, it will probably be obvious. They show a gullwing for erosive OA, or bad carpals for RA, or the pencil in cup for psoriasis, or the fifth metatarsal for RA. If it's not made obvious with an Ant Mini appearance, I like to use this approach to figure it out. I also use this in the real world. Infection. Has one or more, one joint. 2. Symmetric joint space narrowing, erosions. -1/F. Inflammatory. Multiple joints. / Spine degenerative change. In the real world, it's usually just multilevel degenerative change. But in multiple choice world you should be thinking about other things. Shiny corners with early as or flowing syndesmophytes with later as. Dish with the bulky osteophytes sparing the disc space. The big bridging lateral osteophyte is classically shown for psoriatic arthritis. Vertebral osteophyx I. 1. Ankylosing. F. J. Spondyli diffuse paravertebral. L. Psoriatic arthritis, miscellaneous stuff that's sorta in the arthritis category. Systemic lupus erythematosus, the Aunt Minnie look is reducible deformity of joints without articular erosions. Joint space narrowing and erosions are uncommon findings. They can show you the hands with ulnar subluxations at the MCPs on Norgard view, then they reduce on AP because the hands are flat. This ligamentous laxity also increases risk of patellar dislocations. SLE shows reversible ulnar deviation. Jacot's arthropathy, this is very similar to SLE in the hand, people often say them together. You have non-erosive arthropathy with ulnar deviation F the 2nd_5th fingers at the MCP joint. The history is post-rheumatic fever. Dish diffuse idiopathic skeletal hyperostosis. You see ossification of the anterior longitudinal ligament involving more than 4 levels with sparing of the disc spaces, you say dish. The thoracic spine is most commonly used. These guys often have bony proliferation at pelvis, ischial tuberosities, at the trochonters and iliac crests. There is no sacroiliitis, helps you differentiate from as. 99. OPPL, ossification of the posterior longitudinal ligament. This is an ossification of the posterior longitudinal ligament. It is associated with dish, ossification of the ligamentum flavum, and ankylosing spondylitis. It favors the cervical spine of old Asian men. It can cause spinal canal stenosis and lead to cord injury after minor trauma. A key point is that it's bad news in the cervical spine, where it is most common. In the thoracic spine it is usually asymptomatic. Destructive spondyloarthropathy. This is associated with patients on renal dialysis for at least 2 years, and it most commonly affects the C-spine. It looks like bad degenerative changes or CPPD. Amyloid deposition is supposedly why it happens. Mixed connective tissue disease. One unique feature is that it is positive for some antibody, ribonucleoprotein, RNP, and therefore serology is essential to the diagnosis. Juvenile idiopathic arthritis. This occurs before age 16, by definition. What you see is a washed-out hand that has a proximal distribution, carpals are jacked, and ankylosed, premature fusion of growth plates. Serology is often negative, 85%. In the epiphyse knees, you see enlargement of the ES andle/yidend intercondylar nasi at I. Similar to findings in hemophilia. Buzzword, epiphyseal overgrowth. Notice how fucked up the carpals look. Amyloid arthropathy. This is seen with patients on dialysis, less commonly in patients with chronic inflammation such as RA. The pattern of destruction can be severe, similar to septic arthritis or neuropathic spondyloarthropathy. The distribution is key, the bilateral involvement of the shoulders, hips, carpals, and knees being typical. Carpal tunnel syndrome is a common clinical manifestation. The joint space is typically preserved until later in the disease. When associated with dialysis, it's rare before 5 years of treatment, but very common after 10 years, 80%. 100. Section 10. Total hip arthroplasty. Loosening. This is the most common indication for revision. The criteria on X-ray is 2 mm at the interface, suggestive. If you see migration of the component, you can see A11 it. Migration includes varus tilting of the femoral stem. Particle disease, any component of the device that sheds Sheds will cause an inflammatory response. Macrophages will try and eat the particles and spew enzymes all over the place. Things Joe know about particle disease in THA. Most commonly seen in non-cemented hips tends to occur 1 to 5 years after surgery. X-ray shows smooth endosteal scalloping distinguishes from infection, produces no secondary bone response, can be seen around screw holes. Particles are transmitted around screws. Stress shielding. The stress is transferred through the metallic stem, so the bone around it is not loaded. Orthopods call this Wolfflow's law, where the unloaded bone just gets resorbed. The trivia to know is that it, 1, happens more with uncemented arthroplasty, and 2, increases the risk of fracture. Where patterns, it is normal to have a little bit of thinning is the area of weight bearing. This is called creep. It is not normal to see wear along the superior lateral aspect. Wear equals pathologic. Creep equals normal. Heterotopic ossifications, this is very common, 15 to 50%. It's usually asymptomatic. The trivia regarding multiple choice tests is that hip stiffness is the most common complaint. Also in Angstbahn patients, because they are so prone to heterotopic ossifications, they sometimes give them low-dose prophylactic radiation prior to THA. 101. SECR10N11, marrow. This is a confusing topic and there are entire books on the subject. I'm going to attempt to hit the main points and simplify the subject. Bone marrow consists of 3 components: 1. Trabecular bone, the support structure; 2. Red marrow, for making blood; and 3. Yellow marrow, fat for a purpose unknown at this time. Marrow conversion. The basic rules are that yellow marrow increases with age, in a predictable and progressive way. This is usually completed by the mid-20s. You are born with all red marrow, and the conversion of red to yellow occurs from the extremities to the axial skeleton, feet, and hands first. Within each long bone the progression occurs epiphysis I apophysis first, diaphysis, followed by the distal metaphysis, and finally the proximal metaphysis. Red marrow can be found in the humeral heads and femoral heads, as a normal variant in adults. Occurs from the extremities to the axial skeleton, feet, and hands first. Within each long bone the progression occurs epiphysis I apophysis first, diaphysis, followed by the distal metaphysis, and finally the proximal metaphysis. Red marrow can be found in the humeral heads and femoral heads, as a normal variant in adults. 1R or / I. Red marrow converts to yellow marrow from distal to peripheral. / Persistent I red marrow. So as a child you have diffuse red marrow except for ossified epiphyses and apophyses. As an adult you have yellow marrow everywhere except in the axial skeleton and proximal metaphyses of proximal long bones. I. Baby, child, teenager, adult. 1. Few pearls on marrow. Yellow marrow increases with age, as trabecular bone decreases with osteoporosis, yellow marrow replaces it. TL is your money sequence, yellow is bright, red is darker than yellow, near ISO and tends to muscle. Red marrow should never be darker than a normal disc or muscle on TL, think about muscle as your internal control. Red marrow increases if there is a need for more hematopoiesis, reconversion, occurs in exact reverse order of normal conversion. Marrow turns yellow with stress I degenerative change in the spine. This question can be asked in 3 main ways. 1. What is the normal pattern of conversion? 2. What is the normal pattern of reconversion? 3. What areas are spared I normal variants? 1. The epiphyses convert to fatty marrow almost immediately after ossification. Distal then proceeds medial, diaphysis first, then metaphysis. 2. The pattern of reconversion. This occurs in the reverse order of normal marrow conversion, beginning in the axial skeleton and heading peripheral. The last to go are the more distal long bones. Typically the epiphyses are spared unless the hematopoietic demand is very high. Spine, flat bones, long bone metaphysis, long bone diaphysis, long bone epiphyses. 3. Patchy areas of red marrow may be seen in the proximal femoral metaphysis of teenagers. The distal femoral sparring is especially true in teenagers and menstruating women. 103. Leukemia, proliferation of leukemic cells results in replacement of red marrow. Marrow will look darker than muscle, and normal discs on TL. On stir may be higher than muscle because of the increased water content. T2 is variable, often looking like diffuse red marrow. Gamesmanship. They can show leukemia in two main ways: 1. Lucent metaphyseal bands in a kid, 2. TL-weighted MRI showing marrow darker than adjacent discs and muscle. Remember that red marrow is still 40% fat, and should be brighter than muscle on TI. Most infiltrative conditions affect the marrow diffusely. The exceptions are multiple myeloma, which has a predilection / or focal, speckled deposits, and Waldenström's macroglobulinemia, which causes infarcts. T1 SAG, marrow is darker than disc. Chloroma, granulocytic sarcoma, just say destructive mass in a bone of a leukemia patient. It's some kind of colloid tumor. 104. Section 12. Metabolic I miscellaneous. Calcium hydroxyapatite. Most pathologic calcification in the body is calcium hydroxyapatite, which is also the most abundant form of calcium in bone. Calcium hydroxyapatite deposition disease equals calcific tendinitis. The calcium is deposited in tendons around the joint. The most common location for hydroxyapatite deposition is the shoulder. Specifically, the supraspinatus tendon is the most frequent site of calcification, usually at the insertion near the greater tuberosity. The longus colli muscle is also a favorite location for multiple-choice test writers. It may be primary, idiopathic, or secondary. Secondary causes worth knowing are chronic renal disease, collagen vascular disease, tumoral calcinosis, and hypervitaminosis D. Osteopoikilosis. It's just a bunch of bone islands. Usually in epiphyses, different from blastic mets or osteosarcoma mets. It can be inherited or sporadic, but if you are forced to pick a pattern, I'd go with autosomal dominant. Mets vs osteopoiky/osis. Osteopoikilosis tends to joint-centered. Sclerotic Mets will be all over the place. Sclerotic Mets believe in nothing Lebowski. Trivia: osteopoikilosis patients tend to be keloid formers. Osteopathia striata, linear, parallel, and longitudinal lines in metaphysis of long bones. Doesn't mean shit, usually, but can in some situations cause pain. Engelmann disease. This is also known as progressive diaphyseal dysplasia or POD. What you see is fusiform bony enlargement with sclerosis of the long bones. This is a total zebra that begins in childhood. Things to know. Bilateral and symmetric. It likes the long bones, usually shown in the tibia at 0.5 hot on bone skin. It can involve the skull, and can cause optic nerve compression. 105. Pigmented villonodular synovitis, PVNS. PVNS is an uncommon benign neoplastic process that may involve the synovium of the joint diffusely or focally. It can also affect the tendon sheath. Intra-articular disease, basically it's synovial proliferation and hemosiderin deposition. The knee is by far the most common joint affected, 65 to 80%. On plain film, features you will probably see are a joint effusion with or without marginal erosions. Osseous erosions with preservation of the joint space, and normal mineralization is typical. It is not possible to distinguish PVNS from synovial chondromatosis, see below, on plain film. MRI will be obvious with blooming on gradient echo, and this is the most likely way they will show this. Treatment is with complete synovectomy, although recurrence rate is 20 to 50%. PVNS diffuse blooming. Trivia: unusual in kids but when present is typically polyarticular. Giant cell tumor of the tendon sheath, PVNS of the tendon typically found in the hand, palmar tendons. Can cause erosions on the underlying bone. Will be soft tissue density, NBTL, and T2 dark, contrasted to a glomus tumor, which is TL dark, TL bright, and will enhance uniformly. Primary synovial chondromatosis. There are both primary and secondary types, secondary being the result of degenerative changes in the joint. The primary type is an extremely high-yield topic. It is a metaplastic true neoplastic process, not inflammatory, that results in the formation of multiple cartilaginous nodules in the synovium of joints, tendon sheaths, and bursa. These nodules will eventually progress to loose bodies. It usually affects one joint, and that one joint is usually the knee, 70%. The popular is usually a person in their 40s or 50s. Joint bodies, which are usually multiple and uniform in size, may demonstrate the ring and arc calcification characteristic of chondroid calcification. Treatment involves removal of the loose bodies with or without synovectomy. PVNS synovial chondromatosis. Benign neoplasia, benign neopla IA. Associated WIT_H_H_E_ Marthr, OS, is not associated with HE marthraces. Never calcifies, may calcify. Secondary synovial chondromatosis, a lower yield topic than the primary type. This is secondary to degenerative change and typically seen in an older patient. There will be extensive degenerative changes, and the fragments are usually fewer and larger when compared to the primary subtype. Pituitary gigantism. If they happen to show you X-rays of Andre the Giant, look for widening of the joint space in an adult hip, can be a classic buzzword. Late in the game the cartilage will actually outgrow its blood supply and collapse, leading to early onset osteoarthritis. The formation of endochondral bone at existing chondroosseous junctions results in widening of osseous structure. Diabetic myonecrosis. This is basically infarction of the muscle seen in poorly controlled type 1 diabetics. It almost always involves the thigh, 80%, or calf, 20%. MRI will show marked edema, with enhancement, and irregular regions of muscle necrosis. You should not biopsy this, it delays recovery time, and has a high complication rate. Lipoma arborescens. This is a zebra that affects the synovial lining of the joints and bursa. The buzzword is frond-like depositions of fatty tissue. It's seen in late adulthood, 50s to 70s, with the most common location being the suprapatellar bursa of the knee. Although it can develop in a normal knee, it's often associated with OA, chronic RA, or prior trauma. IT's usually unilateral. On MRI it's going to behave like fat, TL, and T2 bright with response to fat saturation. Lipoma arborescens. A sneaky trick is to show THJS on gradient, and how you pick up the chemical shift artifact at the fat fluid interface. This could AJSO be shown on ultrasound with a frond-like hyperechoic mass, and associated joint effusions. 107. AVN of the hip, variety of causes including Perth ES in kids, sickle cell, Gaucher S, steroid use etc. It can also be traumatic with femoral neck fractures. Degree of risk is related to degree of displacement disruption of the retinacular vessels. AVN of the hip typically affects the superior articular surface, beginning more anteriorly. Double line sign, best seen on T2, inner bright line, granulation tissue, with outer dark line, sclerotic bone. Seen in 80% of cases. Rim sign, best seen on T2. T2. T2, high T2 signal line sandwiched between two low signal lines. This represents fluid between sclerotic borders of an osteochondral fragment and implies instability. Stage 3. Crescent sign, seen on X-ray, optimally frog leg, refers to a subchondral lucency seen most frequently anterolateral aspect of the proximal femoral head. It indicates imminent collapse. Stages of osteonecrosis, O0 equals normal, O1 equals normal X-ray, edema on MR, O2 equals mixed lytic I sclerotic. O3 equals crescent sign, articular collapse, joint space preserved. O4 equals secondary osteoarthritis. Thalassemia, this is a defect in the hemoglobin chain, can be alpha or beta, major or minor. From the MSK radiologist perspective, we are talking about hair-on-end skulls, expansion of the facial bones, rodent faces, expanded ribs, jail bars. It is frequently associated with extramedullary hematopoiesis. Alas IWM obliterate sinuses. CKLE cell. WTLL not obliterate sinuses. 108. SEC110N13, Paget's. A relatively common condition that affects 4% of people at 40, and 8% at 80, actually 10%, but easier to remember 8%. MF. Most people are asymptomatic. The pathophysiology of Paget's is not well understood. The bones go through 3 phases which progress from lytic to mixed to sclerotic, the latent inactive phase. The phrase wide bones with thick trabecula make you immediately say Paget's, nothing else really does that. Lytic usually asymptomatic equals I. Mixed elevated alkaline 1-phosphate. Fractures I. Sclerotic elevated hydroxyproline. J. More fractures. Sarcomas 1A. ________ ma. Develop. Acorns in 2 flavors, 1 monostotic and 2 polyostotic, with the poly subtype being much more common, 80 to 90%. Paget.s buzzwords I signs. Signs, blade of grass sign, lucent leading edge in a long bone. F. Skull. Large areas of osteolysis in the frontal and occipital bones, osteoporosis. J. Circumscripta, in the lytic phase. Phase. The skull will look cotton wool in the I mixed phase. Involves both inner and outer table, fibrous dysplasia. Underscore 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 faft underscore s the out, underscore, able, underscore 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 spine cortical thickening can cause a picture frame sign same as I. Osteopetrosis. Also can give you an ivory vertebral body. I. 1pe16 most common bone affected. Alway, I involves the iliopectinia, non. J. The pelvic brim. J. A dash a dash a dash a dash a dash dash a 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 dash dash. Paget's on other imaging modalities. MRI, there are 3 marrow patterns that C1OSELY, but not exactly, follow the phases on X-ray. Dash dash. Underscore underscore dash underscore underscore. One lytic I early J heterogeneous T2, TL is I mixed J iso intense to muscle, with J T2 signals. Sclerotic J underscore low NAL on TL and T2. This vs that, malignant transformation vs active disease. Both are T2 bright and will enhance. Malignant transformation will lose the normal TL signal Gus like a cancer would. Best sequence dot for distinguishing the two. TL pre-con. Nuclear medicine. The primary utility of a bone scan is in defining the extent of disease, and to help assess response to treatment. The characteristic look for Paget's is whole bone involvement. For example, the entire vertebral body including the posterior elements, or the entire pelvis. The classic teaching is that Paget's is hot on all 3 phases, although often decreased or normal in the sclerotic phase. 111. Section 14, Ultrasound. It's absolutely incredible that I even need to go over this, but dinosaur radiologists love this stuff. Anisotropy, the most common and most problematic issues with ultrasounding tendons is this thing called anisotropy. The tendon is normally hyperechoic, but if you look at it when it's not perpendicular to the sound beam it can look hypoechoic, injured. It's the biggest pain in the ass. Supraspinatus tendon, as it curves along the contours of the humeral head long head of the biceps, in the bicipital groove. Normal appearing hyperechoic tendon. Exact same tendon, now appearing hypoechoic, when scanned non-perpendicular. Head long head of the biceps, in the bicipital groove. Normal appearing hyperechoic tendon. Exact same tendon, now underscore. Dash. Tenosynovitis, as discussed above there are a variety of causes. If they show it on ultrasound you are looking for increased fluid within the tendon sheath. You could also see associated peritendinous subcutaneous hyperemia on Doppler. Tenosynovitis, increased fluid in the tendon sheath. Plantar fasciitis, this is another pathology that lends itself to a what is it type of ultrasound question. Question. Hopefully, they at least tell you this is the foot, they could label the calcaneus. The finding will be thickening of the plantar fascia, greater than 4 millimeters, with loss of the normal fibrillar pattern. If you see calipers on the plantar fascia, this is going to be the answer. Plantar fasciitis. Trivia, most commonly involves the central band, there are 3 bands, people who don't know anatomy think there are 2. Calcific tendinitis, as described above, this is very common and related to hydroxyapatite. The most common site is the supraspinatus tendon. Tendon, near its insertion. It will shadow just like a stone in the GB. Dash. Tenosynovitis, as discussed above. SEC110N1S procedures. An important point to remember is that the target is not actually the joint. The target is the capsule. In other words, you just need the needle to touch a bone within the capsule. The trick is to do this without causing contamination or damaging an adjacent structure, like an artery. General tip: avoid putting air in the joint, this will cause susceptibility artifact. Hip: the general steps are as follows. 1. Mark the femoral artery. 2. Internally rotate the hip, slightly, to localize the femoral head-neck junction, your target. 3. Clean and numb the skin. 4. Advance a 20 to 22 gauge spinal needle into the joint, straight down on the superior head-neck junction. 5. Inject a small amount of contrast to confirm position. Contrast should flow away from the tip. If the contrast just stays there, it's not in a space. 6. Put the rest of the contrast in. Trivia: the capsule is widest at the head-neck junction. Trivia: the cocktail injected is around 14 centimeters cubed total, 4 centimeters cubed lidocaine, LOCC Visipac, and only about O.LCC GD. Shoulder: the general steps are as follows. 1. Supinate the hand, externally rotate the shoulder. 2. Clean and numb the skin. 3. Advance a 20 to 22 gauge spinal needle into the joint, straight down on the junction between the middle and inferior thirds of the humeral head, 2 mm inside the cortex. 4. Once you strike bone, pull back 1 mm and tum the bevel towards the humeral head. This should drop into the joint. 5. Inject a small amount of contrast to confirm position. Contrast should flow away from the tip. If the contrast just stays there, it's not in a space. 6. Put the rest of the contrast in. Trivia: the cocktail injected is around 12 centimeters cubed total, 4 centimeters cubed lidocaine, 8 centimeters cubed Visipac, and only about O.LCC GD. 114. L. / Special situations, problem solving. So there are 3 main reasons that you might get asked to put a needle in a joint. 1. Needs arthrogram to evaluate the labrum. 2. Needs steroid lidocaine injection for pain management. 3. Possible joint infection. Needs apiration. Only one of these is going to end up getting imaged, the arthrogram. The other 2 just need the needle in the correct spot, and it doesn't matter what you had to do to get it there. Scenario 1: patient is allergic to, has a phobia of GD, but needs an arthrogram. You could try a CT arthrogram. So not GAD, just Visipac and lidocaine. Scenario 2: patient is allergic to, has a phobia of CT contrast, Visi or Omni, but needs a steroid joint injection. You can inject air into the joint instead of Visi to confirm placement, then put the steroid in. Scenario 3: patient is allergic to, has a phobia of CT contrast, Visi or Omni, but needs an arthrogram. This situation is different. You can't inject air because you will end up with a big blooming mess on MR. CT isn't an option either, because obviously you need the CT contrast, or it's not an arthrogram. Your only choices would be to either 1. Premedicate them, or 2. Use the force, trust your feelings, and hope you can get in the joint without confirming positioning with fluoro. 115. Blank for notes I scribbles. 116. Chapter 12. Prometheus Lionheart. SEC110N1S procedures. An important point to remember is that the target is not actually the joint. The target is the capsule. In other words, you just need the needle to touch a bone within the capsule. The trick is to do this without causing contamination or damaging an adjacent structure, like an artery. General tip: avoid putting air in the joint, this will cause susceptibility artifact. Hip: the general steps are as follows. 1. Mark the femoral artery. 2. Internally rotate the hip, slightly, to localize the femoral head-neck junction, your target. 3. Clean and numb the skin. 4. Advance a 20 to 22 gauge spinal needle into the joint, straight down on the superior head-neck junction. 5. Inject a small amount of contrast to confirm position. Contrast should flow away from the tip. If the contrast just stays there, it's not in a space. 6. Put the rest of the contrast in. Trivia: the capsule is widest at the head-neck junction. Trivia: the cocktail injected is around 14 centimeters cubed total, 4 centimeters cubed lidocaine, LOCC Visipac, and only about O.LCC GD. Shoulder: the general steps are as follows. 1. Supinate the hand, externally rotate the shoulder. 2. Clean and numb the skin. 3. Advance a 20 to 22 gauge spinal needle into the joint, straight down on the junction between the middle and inferior thirds of the humeral head, 2 mm inside the cortex. 4. Once you strike bone, pull back 1 mm and tum the bevel towards the humeral head. This should drop into the joint. 5. Inject a small amount of contrast to confirm position. Contrast should flow away from the tip. If the contrast just stays there, it's not in a space. 6. Put the rest of the contrast in. Trivia: the cocktail injected is around 12 centimeters cubed total, 4 centimeters cubed lidocaine, 8 centimeters cubed Visipac, and only about O.LCC GD. 114. L / Special situations, problem solving. So there are three main reasons that you might get asked to put a needle in a joint. 1. Needs arthrogram to evaluate the labrum. 2. Needs steroid lidocaine injection for pain management. 3. Possible joint infection. Needs aspiration. Only one of these is going to end up getting imaged, the arthrogram. The other two just need the needle in the correct spot, and it doesn't matter what you had to do to get it there. Scenario 1. Patient is allergic to, has a phobia of, GD, but needs an arthrogram. You could try a CT arthrogram. So not GAD, just Visipac and lidocaine. Scenario 2. Patient is allergic to, has a phobia of, CT contrast, Visi or Omni, but needs a steroid joint injection. You can inject air into the joint, instead of Visi, to confirm placement, then put the steroid in. Scenario 3. Patient is allergic to, has a phobia of, CT contrast, Visi or Omni, but needs an arthrogram. This situation is different. You can't inject air because you will end up with a big blooming mess on MR. CT isn't an option either, because obviously you need the CT contrast, or it's not an arthrogram. Your only choices would be to either, 1. Pre-medicate them, or 2. Use the force, trust your feelings, and hope you can get in the joint without confirming positioning with fluoro. 115. Blank for notes I scribbles. 116. Chapter 12. Prometheus Lionheart, MD, Neuroradiology.